Uh, just to recap, we started special concerns or special challenges which you will have if you are dealing with a geriatric patient. Okay, so we just try to correlate some of the physiological, pharmacological, and anatomical changes and correlate them with the practical conduct of anesthesia. Okay, so today I just will try to just taking in consideration few of the surgeries or few of the scenarios which you will be facing when in elderly patient. Okay, so we just try to chalk out what are the scenarios which you will be facing in elderly patient. Yeah. Actually, any surgery can be there in an elderly patient, but there are some scenarios which will be more common. Okay, and they may be asked even in oral exam, or they may part of any MCQs exam or SAQs exam in different exam which you are targeting. Okay, so I will just start with the scenario of a 70-year-old male with fractured neck of femur. Okay, so this will be a scenario which you will be facing not only in exam but also in practical conduct of anesthesia. Okay, so I will just ask, is this important that how this fracture occurred? Would you like to know that this neck of femur fracture occurred because of something? Would you like to ask some question about it? Is it important? Anyone wants to comment, please? Is it of some importance that how this fracture actually occurred? Anyone, please? Tayyab, is it important to know how this fracture occurred? Anyone wants to speak out? Please. Okay, the thing which I wanted to know that because the fracture may occur spontaneously because patient slipped in the bathroom or anywhere, or there may be some medical condition in which there is loss of consciousness, which may be any neurological problem, any cardiac problem, any respiratory problem, any electrolyte imbalance, which became the cause of fall. Okay, so this thing should be in your mind that if you are dealing in an old age fracture, or actually this should be the in any other patient as well, that what was the mechanism of injury, but this is more important in elderly age group, which in which there is more chances of having any problem which may become the cause of the fracture. Okay, because in any other patient it may be because of malignancy, because of osteoporosis, any cause in which is in addition to the actual accident or fall which lead to the fracture. But in elderly population, you should be taking in consideration that there may be some electrolyte imbalance like hyponatremia, okay, which may be there in elderly population. Okay, and there may be some cardiac arrhythmias which occurred and which lead to fall of the patient, or there may be any other reason as we discussed. Okay, so this is first thing to know. Then if you are having that patient, would you like to like do some investigation, or what should be your approach in this in this patient? If all of you will remain mute, it will be not as beneficial as compared to if you are people are interacting.
Sir, investigation for what? His mean to
Like
say it's
if you have a patient with fracture neck of femur, okay. So like I will rephrase my question. How will you evaluate this patient? Would you like to have some evaluation in this patient? Like one aspect I told you that you should be considering the mode of fracture, that how this fracture occurred, how much is the history, how much is the duration before that patient is presented to you. Okay. So what other things would you like to see?
Sir, labs most likely, as you mentioned, the electrolytes, especially the calcium level, and
Calcium
it's
level. Okay.
yes, sir, maybe it's maybe pathological due to hyperparathyroidism. We also look into that,
Okay. What else?
and sir, mm, osteoporosis.
Okay. Would you like to because there are more chances of any having chronic diseases like hypertension or ischemic heart disease. Okay. So
Yes, sir.
because you will be discussing with the surgeon, and there will be certain reasons for delaying the surgery. Otherwise, you will not be delaying. You will, because what is the risk in this patient? What is the
Yes,
important?
sir.
Why you
Sir,
cannot delay?
avascular necrosis may occur if we unwanted delay that surgery.
Okay, what else? What else?
Mobility and diabetes risk.
Yes, this is the most important factor, which is which you should be considering when you are dealing with such patient. Because if you delay the patient, and the risk of embolism will be increasing. Okay, so this is the most important thing for which you cannot delay this patient. Okay, so what else? Like, would you like to, for example, if this patient happens to be hypertensive, would you like to do any investigation at that time?
Yes, sir. Patient ECG, echo, and
Like, just consider this patient. Would you like to send this patient for echo? This
no,
is
sir. If there is not any underlying cardiac disease, I don't think so. We recommend echo, but
even
we
even for example, if you I've told you that this patient is hypertensive. You check the blood pressure. Blood pressure is 180 by 100. Okay. Will
okay,
you
sir.
send the patient? Can you assess the exercise tolerance in this patient at the moment, or even
Yes,
before
sir.
surgery? Is it easy to evaluate the functional class of elderly patient having osteoarthritis?
Yes, sir. Then we have to go for it.
We have to go for what?
So exercise tolerance test for
No,
her.
exercise tolerance test. If patient, this old man is having osteoarthritis, would you like to have exercise tolerance test?
No, 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 sir. If patient has osteo, then we don't go for it.
Then what do you do? What is the other test which you do? That is a dobutamine stress echo. Okay, or
Okay.
thallium stress thallium scan. Stress thallium scan will tell you the perfusion defect if they are present, or dobutamine stress echo will tell you that what is the condition of the heart. But in this scenario, you will not delay the patient for these investigations. Okay, you can have quick ABGs to see the hemoglobin, or you can do immediately the test the results which you will be getting, you can get quickly. Okay, and you will be arranging the blood and blood products. Okay, then you will be discussing with the surgeon what type of fracture is it. If it is a specific, there are like some concerns related to specific fracture in which there is more chances of bleeding. I think pericapsular or something like that. You can see some source in which you will find that what type of fracture there are more chances of bleeding. I cannot recall at the moment. I will try to search in it.
Yeah.
Sorry.
So basically, उसमें ये देखना होगा ना कि whether they want to do a short gamma nail or a long gamma nail, or they want to do a arthroplasty.
Yes.
So whether they want to do cementing, whether they want to do non-cementing. So
yes.
that will drive your management basically.
Yes. That's what I wanted to say. And you will be discussing with the surgeon what's their plan. So
short gamma nail is the least invasive. So if the patient is very debilitated and you are doing a palliative procedure, short gamma nail is the procedure to go for.
Yes. Okay. So we decided that we will not be delaying the surgery for tiresome investigation because it will not change any management plan. Okay. So you will be discussing with the surgeon what's their plan and you will be proceeding. You can arrange the blood and blood products if the hemoglobin is low. Okay. And you will be proceeding for it. Okay. So now what other challenges will you have in this patient in addition to any elderly patient? What other problems you will have when you will be planning for anesthesia? What should be in your mind?
Difficult airway, difficult.
Okay.
Difficult airway.
Difficult airway can be there in any elderly patient. So if you just try to think what specific concern you can have. Yes, Vikas? You have raised the hand. Yes. I'm sorry. Yes, Dr. Abu Bakr, Ubaid, you want to say something?
Yes, sir. I believe mobilization will be difficult for such patients as.
Yes. Hold on. This is the point we have to discuss, that you will go for general anesthesia or regional anesthesia. For example, we are just discussing that if you are planning for regional anesthesia, what will be your challenges? Because as we said that this patient may be because at risk for embolism, so maybe this patient has already been started with anticoagulants. Okay. So this will be that you have to look into consideration when you are planning epidural or spinal. You have to think about this thing. Another thing is that in fracture neck of femur, you will not be able to have proper position of the patient for spinal, and you will have problem for that. So what are the things which you can do to tackle this thing? Like you have a patient, you decided that you will do spinal or epidural, and there is no problem related to coagulation that you have dealt with. You have either passed the time or the patient is not receiving. What are the ways to cope the problems related to the positioning? Yes.
We can give fascia iliac block to position the patient.
Yes, this is one option. This is one
apart
option.
From that, we can give a little bit of fentanyl, L-fentanyl at the time of positioning, or little bit of propofol.
Propofol or something else, because propofol you can lose the airway.
We do it day in, day out with 10 or 20 milligram of propofol and we turn them out.
Actually, you are absolutely right, because practical conduct of anesthesia is a little bit different than sometime in the exam. Okay, so in the exam, if you say propofol, you can be caught by the examiner that you gave even 10 milligram of propofol and you lose the airway. Okay, so then it will be
10 milligram will be conscious sedation, boss. Na?
You are absolutely
10-20 milligram will be conscious sedation. It won't.
Okay, what else? What else than propofol?
Midazolam, you can give midazolam. You can give
ketamine.
A small dose of ketamine. Okay, and
ketamine problem with ketamine is delirium. In these patients, old age patients, they are at high risk of post-operative cognitive dysfunction.
Exactly. So you have to decide. You can actually you can use a very small dose of ketamine with midazolam, which will cover not only, because only midazolam will not be, you will not be able to give the pain relief, because the problem is not the cooperation or anxiety in this scenario. The problem is the pain. Okay, because even a small bit of pain can create problem. So recently they have devised a block. Because I don't have too much information about it, but there is a block which is named as PANG block. Have you heard of its name? There is a block.
Which block?
PANG block. Just let me. Just a second, please. Okay. Actually, this is a new block described only recently, a few years ago, and it's called as pericapsular nerve block. Okay. It is being used to do the positioning because of pain in hip fractures. Okay. So this is one of the option, and this may be asked in your exam. So you can read about it. I will share this document. So this is one of the block which is now used, pericapsular nerve group block. Okay. I'm not I don't have much of the knowledge about this block, but I will share this data for you. Okay. So this is one of the technique which you can use, that PANG block. Ketamine, like you say, sedation with or without ketamine, or you can use fascia iliaca or femoral nerve block in that area, that you will be getting the positioning done. Okay, but you have to keep in consideration that you have to calculate the toxic dose, and you have to give accordingly. Like you should be using lidocaine and in a lesser concentration to have a volume, so that it is not causing that much problem for you. Number one, if you are saying sedation, you have to say that you should be looking for that you will be cautious if the patient can lose the airway. Okay, so you should have the counter question which can be there in the mind of the examiner. So if you know about it, then you can easily tackle because there is no absolute thing. Okay, then another thing, during positioning, any other problem other than pain? Can any other problem occur? We are not moved forward. We are only talking about the positioning. Can any problem occur while positioning other than pain? Okay, Mohsin, your point that we are not giving a very high dose. Okay, we will be using only very small dose, 0.25, 0.5 milligram per kg, which will not cause that much thing. Okay, so that's a relative thing. And what I suggested, that whenever you are using ketamine small dose, you can combine it with midazolam. So it will blunt some of the bad effects of ketamine. Okay. So I will repeat my question, that what problems you can face only while positioning?
We may dislodge an emboli.
Yes. So this is important thing. Okay. Right at the time of positioning, patient can lose the consciousness. So because of pulmonary embolism. Okay. Pulmonary embolism, fat embolism. So this thing should be in your mind. Okay. That this complication can occur. So some people, this is another practical advice or a suggestion to everyone, that usually people don't attach monitor while performing spinal block. So it is highly recommended that you should attach the monitor while you are performing the block, because people the wires are being stretched. So sometimes especially the technicians, they will not be very happy if you are asking them to attach the monitor while you are performing the block. So it is suggested that you should be careful about it, because in any other patient there can be development of vasovagal. So vasovagal you can also avoid or detect early if you have the monitor attached, because otherwise you may not be able to pick the vasovagal if the monitor is not attached. Okay, so this is the one point I wanted to highlight. Okay, what else? If you are performing regional anesthesia, so what will be difference between choice between regional and this spinal versus epidural? In which scenario would you like to have spinal, and in which scenarios would you like to have epidural? What will be the advantages? Usually it will depend on the surgical team, okay, and the post-operative care which is being offered, okay. If because the advantage of epidural will be that you can continue it for post-operative period. It will reduce the stress, it will reduce the chances of pulmonary embolism, and if the surgery is prolonged, you can continue it for pain relief. But there can be other plans as well, that if you give spinal and at the end you can have like a femoral nerve catheter or fascia iliaca block or things like that. So you can have in different scenarios, you can have different plans for it, okay. And especially if you are giving general anesthesia, even then you can combine some block. You can give even with general anesthesia, you can place epidural and you can use it for post-operative pain. Like you should be in mind, there are different ways you can underwent this this procedure, okay. So the advantages will be, as we discussed, that the challenges will be related to the positioning. Challenges will be related to the anticoagulants. If you are taking heparin or Claxane, you have to make sure about the problems related to it, okay. Like if the patient is taking anticoagulant in therapeutic dose, you have to wait for 24 hours for Claxane. If it is prophylactic dose, you have to wait for 12 hours. And similarly, you have to, if you have placed epidural catheter, you have to remove it accordingly, okay. So these are the things which you should be considering. Any other point? Vikas, would you like to add something?
Yeah, the boss, I just wanted to make sure that epidural, why you want to give an epidural in the later position? Why not for a PCA morphine or something of that sort? Is it because of the logistic there? Because I'm working in NHS and I have not seen a epidural being given for a neck of femur fracture with a 70 or 80-year-old who is already anticoagulant and difficult positioning. And
Exactly. Actually, so, like you use morphine PCA. So morphine has some questions to be used in elderly patient. Okay. Because of
that is what PCA morphine would be. Do that will be patient controlled analgesia, and patient controlled analgesia you don't get any. The risk of respiratory depression is very minimal.
Exactly.
Because
you are absolutely right, because yes, actually thing is that the people different in different logistics or different scenarios. That's what I use the word, that scenario in which you are using.
That's why I specifically asked that is this the scenario back home in Pakistan that you guys are not using any PCA morphine there, or what is the logistics like?
Logistics, the PCA is not available in all parts of the world. Not only in Pakistan, even in I'm not working in Pakistan, I'm working in Saudi Arabia. It's not available in all the centers of Saudi Arabia. Okay, so PCA is something which not everyone is familiar, even in developed countries. Even in the countries where actually you will find some in some of the hospitals in Saudi Arabia, even all the things which are written in the book are available. I have worked there, King Faisal. Okay. So, but in the hospital where I'm working at the moment, not even unfortunately in our hospital, we are not even offering epidurals post-operatively, because not everyone is familiar to have epidural infusions controlled in the post-operative, because of the logistics and because of the turnover and the situation in our hospital. It's a big center, but it does not have this. So actually, because here our domain is not only to discuss the practicalities, our main focus is to have a good preparation for the exams. Okay. So that's why for exam purposes, sometimes some majority of the things which we are doing are not, we cannot defend in the exam. Practically, whatever we are doing it. So that's the point. So yes, practicalities are a little bit different than exam logics in the to be like which you need to be defend in the exam. Okay, so that's what I was trying to tell. I hope because there is a guideline for fractured neck of femur, you must have seen the class. the
Yeah,
AAGPI.
I have seen
AAGPI.
now there is another paper by NICE which says that there is not much difference whether you do it regional versus general anesthetic, and also they are not advocating do it within 36 hours. So basically,
Yeah.
because the short-term and long-term complications are pretty much similar, and if you do it within 36 hours, only your length of stay is getting decreased. Otherwise, outcomes are pretty much similar.
Yes, actually, there are a number of things which will be depending, like we are discussing here. I will discuss in the same time another point, which is not directly related to this point. We are giving adductor canal block for post-operative pain for knee replacement. Okay. So I will repeat adductor canal block, in which we only block saphenous nerve, okay, for knee replacement pain. Okay. Just tell me, is it of any advantage if you are not following ERAS protocol, enhanced recovery after surgery protocol, and you are not interested in early ambulation of the patient? Will there be any advantage?
We do adductor canal block for our knee, and
yes,
it does improve the mobility.
Yes, I will repeat the scenario for everyone. The people who don't know about it, I will try to explain in a way that everyone is knowing it. The thing is that usually femoral nerve block can be given for a patient post-operative pain for knee replacement. Okay, femoral nerve block can be given. So why we are giving adductor canal block? Specifically because in adductor canal block only saphenous nerve will be blocked. Saphenous nerve will be is purely sensory nerve. So there will be no motor blockage. So the advantage will be that there is no paralysis of the quadricep muscles, and a patient is able to have the physiotherapy done, and patient can be embolized early if you have the facility or you are following the protocol for ERAS, enhanced recovery after surgery. Okay. But for example, now I give you a scenario that the hospital in which you are working is not following protocol for ERAS, and patient is not having any fast track mobilization. Okay. So is there any advantage of giving adductor canal block in that patient? No, there is no advantage. Rather, if you give femoral nerve block, it will give you a superior analgesia. It will have, it is easier to perform. And especially if there is a risk of any risk of hematoma or anything like that, because adductor canal is relatively deep block as compared to femoral nerve block. Okay. So this is the actually discussion. But in the exams, of course, or if you are working in a place where they are following a specific protocol, then it will be advantages. Am I right?
Yeah, I think you are pretty much right there.
Yes. Okay. So this is one of the anesthesia tutorial on the fractured neck of femur. Okay. They have highlighted some of the things which we have already discussed. We will be having a multidisciplinary team, because in Western countries, these patients may be shifted from or nursing home. So there will be concerns related to old age, neglected, depressed patient. Okay. In other part of the world, maybe scenarios may be a little different. So we started from the scenario that what will be the cause of the fracture? Is there any underlying problem which lead to the fall of the patient and then for subsequent fracture? So you have to consider that problem as well. Okay. And then you will be discussing with the surgeon, what is their plan, what are they going to do? And then you will be doing in the assessment, you will be having the same assessment which you will be doing in any elderly patient. But in this scenario, you cannot delay it for a long time. You will try to have an analgesia if you want. Even if you want to, no, even if you are giving general anesthesia, even for the shifting of the patient from the bed to the trolley to the operation theater bed, you can give even this block in the emergency. This as the block I told you, PANG block or fascia iliaca or femoral nerve block by any way. Okay. You will not be delaying the surgery, and you can do a quick ABGs and you can have a CBC report or electrolytes if you can do. You can send all the reports, but you will not delay the surgery, and you will be discussing and with the surgeon about X-ray is not necessary. If you are suspecting any pneumonia or heart failure, you can do it. Okay. If you have a patient like we discussed in our first discussion, there are certain problems which are more prevalent in elderly patient. So one of them is atrial fibrillation, or for any other reason, patient may be taking aspirin, okay, or any antihypertensive medication. So you will have to consider those things accordingly. Okay. These are the things, and as this is from the guidelines, AAGBI guideline, they have that you will be only delaying, or you will only be trying to optimize if there is significant anemia, there is significant electrolyte imbalance like sodium less than 120, hemoglobin less than 80 or 8 gram in different, or significant potassium, uncontrolled diabetes. In that scenario, you can have some time to optimize it, because it will improve the outcome. Otherwise, you will not delay it. Okay, you will not delay it for lack of this is actually purely according to the guidelines base. These are the points taken from the AAGBI guidelines. Okay, so you can review these things. Okay, so any other point, because rest of the things, these are the things which are not usually written in the books. So I just try to highlight these of the factors. Any question or any comment up till now? Yes, any comments about it? Because this is a very important scenario, and especially the people who are listening from Saudi Arabia, who are going for Saudi Commission consultant evaluation exam. This is a frequently asked question, fracture neck of femur. Even in European exam, they can ask you this question. Yes, Dr. Siddiq. Yes, Dr. Lina.
I'm asking about echocardiography test. It is routine in elderly patient?
No. Echo will be indicated if there is you know about clinical risk factors, or in some books which is written as clinical risk factors or intermediate predictors. These are old MI, heart failure, angina class 1 and 2, New York Heart Association class 1 and 2, any history of stroke, insulin dependent diabetes mellitus. Okay, if you have a combination of risk factors, like I will repeat again, angina class 1 and 2, Canadian class 1 and 2, old MI, compensated heart failure, that is New York Heart Association class 1 and 2. Okay, and there is a history of insulin dependent diabetes mellitus, there is history of stroke, and there is history of CRF with creatinine more than 2. Or if you are dealing it in micromole, it is more than 176 micromole per liter. Okay, so if you have combination of if you have combination of some risk factors, and you have a patient whose functional class is low, or you are not able to evaluate the functional class because the patient is bedridden, maybe because of fracture or because of osteoarthritis, you cannot evaluate the patient, you cannot do exercise tolerance test. Okay, so in that scenario, you will go for echo, or you will go for stress echo. Okay, or another factor will be, which will be defining it, if you are having a low risk surgery in the same patient. If you have a low risk surgery, you will not go for echo. There is no need for echo in a low risk surgery, like for example incident drainage, like for example simple inguinal hernia, not obstructed or strangulated hernia, simple hernia, you don't need to go for echo. Okay, so this is the concept, that either there are active cardiac conditions, major cardiac predictors, like acute or recent MI is one of the active cardiac condition. Acute or recent MI. Acute MI is within 1 month. Acute MI is within 1 week. Recent MI is within 1 month. Okay. There is unstable angina, like angina at rest class, angina class 3 and 4. There is decompensated heart failure, like there is dyspnea at rest or at minimal activity. And then there is significant arrhythmias, like there is supraventricular tachycardia, there is symptomatic bradycardias. These are significant arrhythmias. And there is severe valvular heart disease, like there is tight severe mitral stenosis or severe aortic stenosis. These are active cardiac conditions. Okay, unstable angina, recent or acute MI. If you have one of them, these of them, then you will be going towards the invasive investigations. Okay, so actually this is a algorithm for cardiac patient for non-cardiac surgery. This is the algorithm which I am just trying to explain to you. There are different words written in European guidelines and American Heart Association guidelines, but actually the result is the same. They are focusing, they are looking at the active cardiac conditions. They are looking at the urgency of the surgery, that whether the surgery is immediate, you cannot delay, like there is emergency surgery, you have to proceed, you cannot delay. Okay, you have to proceed the surgery, and you will be doing the risk stratification. Risk stratification, you will be using invasive monitoring, like intra-arterial blood pressure monitoring, like you are using the medication which are having least effect on myocardial oxygen demand supply ratio. Like you are using opioids, you are not giving too much stress to the patient. You are trying to correct the anemia intraoperatively so that the oxygen carrying capacity is not disturbed. Okay, so these are the things you have to follow if you have a patient with active cardiac conditions and the surgery is urgent or emergent. Okay, so in that scenario, you will not delay the surgery, because you cannot delay the surgery. Okay, if the surgery is non-urgent, and now you have active cardiac condition, you will evaluate the patient, you will send the patient to cardiology, you will optimize the patient. Whatever the reason is, if there is, for example, elective surgery, and you have a patient with severe mitral or aortic stenosis, you will not proceed. You will first correct that thing, and then you will have that surgery. This is the protocol. And then in next step, if there is no active cardiac condition and the surgery is elective, then they are looking at the functional class. Like you are looking at the functional class of the patient, how much is the METs, like for anesthesia, it should be more than 4. Okay, more than 4 METs, like there is a METs classification, and you have to make sure the METs are more than 4. So because if the METs are less than 4, then you will have problem during the conduct of the anesthesia. Okay, and then third category you be looking at is the surgical risk, whether the surgery is mild risk, like superficial surgeries, like hernia surgery, like breast surgery. These are low risk surgeries, incident drainage, and things like that. Or you have intermediate surgery, like body cavity surgeries, okay, like TURP, okay. Or you have high risk surgery, like you have liver transplant, or you have vascular surgeries, okay. So you have a list of the high risk surgeries, intermediate risk surgeries, and low risk surgery. Okay, so you will be, what investigation you need to do is according to the these parameters: functional class, urgency of surgery, clinical risk factors, and active cardiac conditions. Okay, so I hope you got your answer, Dr. Leena. Okay,
Thank you.
okay, so just a few things are left. Just let me show the screen again. Okay, so in addition to standard 1, standard 2 monitoring, in this patient you might need to have invasive blood pressure monitoring. If your patient are suspecting that there will be bleeding, or patient has some risk factors, you can have invasive blood pressure monitoring. In addition to that, you can have point of care hemoglobin. This is HemoQ, or you can have ABGs to see the change in the hemoglobin, or any electrolyte imbalance if you are suspecting in that patient. Okay. If you are giving general anesthesia, you should be having a good multimodal analgesia. Okay, multimodal analgesia with paracetamol, with NSAID, with if you are not having any renal involvement in that patient, you can use, there is not contraindication to use NSAIDs, but you should be careful. If you are dealing an elderly patient, you can expect to have decrease in ill functions. Okay. So this is, we have discussed these common things in our first discussion, okay, like thermoregulation, pressure care, antibiotics, okay, and you will be, same things you will be considering in the post-operative period, okay. So any question about this scenario, this fractured neck of femur? You can have post-operative HDU if you have any doubt, okay. So any question in this scenario? Okay, some of the questions which are being put, please discuss type of nerve loss for below knee amputation. We will discuss inshallah. In next scenario, I will try to cover the question which is being asked. Okay, and aspirin from our guidelines, there is no contraindication with aspirin. Okay. If the patient is on clopidogrel, you have to stop it for 4 to 5 days. And before that, you have to see whether there is risk of thrombosis is more than risk of bleeding. Okay. Whenever you are continuing clopidogrel or you are stopping it, the decision is on the basis of how much is the risk for thrombosis and how much is the risk for bleeding. If there is a patient with high risk for bleeding and high risk for thrombosis, then you may bridge. You need to bridge. Okay. You will convert it into heparin and then you will stop the heparin according to the type of heparin you have used. But if you have a high risk for thrombosis, you cannot stop. Okay. Okay. Okay, so we will finish our discussion here today. Usman Bangash is still here or already left? Because he asked this question. Anyways, thank you very much, all of you. We will continue our discussion next time, inshallah. Next time, I will try to cover a few more scenarios from elderly and then we will move on our next topics. Okay, thank you.